you can take somebody who's age 65 in parts of Florida. Florida tends to has some areas that are higher spending. Just imagine if you moved them to Minnesota and they spend their next 20 years in Minnesota instead of Florida, the government could also give them a Ferrari and they'd still save money.
This is the Gies Download, a podcast from the University of Illinois' Gies College of Business. I'm Tim Sinclair, and today I sit down with Associate Professor of Finance and Director of the Healthcare Research Initiative and Conrad W. and Shirley A. Hewitt Fellow and Deloitte Scholar, David Molitor. David and his team are studying the effects of health on business, and as you'll hear, many of the results are extremely surprising. I expect a lot of things from business schools and from Gies specifically. Learning about healthcare research and initiatives was not one that was on my bingo card. Can you explain what it is that you and your team are doing around healthcare at Gies, and then maybe just as importantly, why?
Yeah, that's a great question. Let me start with just some basic facts that help, I think, center why is health an important area for research in a business school. First one is healthcare is a major sector of the U.S. economy. We spend $4.5 trillion a year in the U.S. on healthcare. That's over $13,500 per person, over 17% of our GDP. And so understanding how healthcare works as a business is important. And perhaps it's one of the most important businesses because, of course, what good is wealth without health? And are we getting good bang for our buck? And I think there's a lot of reasons to think that healthcare as an industry is somewhat unique and might not work as efficiently as other markets that we're used to thinking about. When you shop on Amazon or you go to the grocery store, you might not like the prices you see. They might feel like the prices are too high, but at least you know what they are before you buy them. In healthcare, we deal with an industry where oftentimes you don't know how much the care cost. Your healthcare provider might not even know how much it cost until long after the care has been received. So you might get surprise medical bills. And partly because healthcare can be so expensive and can be a shock, health shocks and the resulting care can be a shock, we, in most areas of healthcare, payments are covered by insurance. So insurance is an intermediary. But what that does is that really complicates choices about what care to receive. If I am trying to decide, should I get an X-ray or an MRI, I'm thinking about how much I'm paying out of pocket, not necessarily how much is going to be paid in total, the total resources put toward it, because that's being covered by the insurance. Now, ultimately, the total amount that insurance companies pay comes back to individuals because we have to cover that through our premiums, or the employers are covering healthcare. You think about the cost of doing business in the United States, one of the major costs of doing business is providing healthcare for your employees. So when you talk about healthcare being expensive, it's not just that, that's hard on an individual's out-of-pocket spending for their own healthcare. Businesses are thinking about every time they hire a new employee, it's what are the costs of hiring that employee? What are the benefits that are going to be provided? And when healthcare costs are going up, and the employer is covering a share of that, that makes it harder for them to give raises at work. And so it kind of, of course, it's an important part of overall compensation, but it's important to be thinking about how do we, if we can find ways to bring down the cost of care while also providing good quality of care, that's just very, very important for many different business decisions. So all of these things are just really at the heart of business and policy, and I think there's no better place to be thinking about these types of issues and markets and in healthcare in particular than in a business school.
I had a teacher my freshman year of high school who literally started class with a big long acronym that read out was there ain't no such thing as a free lunch. Um, and I don't exactly know what his point was right there, other than maybe we weren't going to skate through and get an A. But long term, it basically means somebody is paying for everything somehow, even if it's not you. And it sounds like that has never been more true than when it comes to healthcare. If it seems free or it seems covered, the money is coming from somewhere.
As an economist, I think a lot about budgets, and so if you spend on something, it has to come out of your budget somewhere. And it might not always be salient exactly where it's coming out of, but that's something that in the research that we do here at Gies, we try to make that more salient. Like, how are we funding these things? And at the end of the day, health is important. We want to have better health, and when you have, if you have, you or a loved one has an emergency or health shock, you want to be cared for by the best. Uh, you're not necessarily going to be interested in skimping, on the quality. You want good quality. But what we want to make sure is that when we are spending a lot, that we're really spending it on the things that matter. We want to make sure that when new innovations, new health innovations come online, where we're going to be paying more for them, we want to make sure that it's worth it. And I mean, health is important. It's worth it to pay a lot in some cases, but in other cases, we see examples of waste where money is being spent where it's actually not creating value. In some cases, it could actually be creating harm. So are there ways that we can encourage more of the good stuff? Sometimes it's going to cost us more, but also to trim out some of the stuff that's not generating benefit.
Yeah, nobody wants a discounted heart surgeon, I don't think, or brain surgeon. Let's get into the weeds just a little bit in terms of, with all of that said, what then are you doing and what is your team doing at Geese on a day to day basis to try to, maybe it's just understand the problem better? Maybe it's fix the problem, maybe it's legislate. I don't know the answer, but what is it that you and your team are working on there to try to battle some of this?
Let's draw an analogy to health. If you want to solve a problem, the first step is to diagnose it. Then once you have a diagnosis, then you can think about the appropriate treatment. So I think here at Geese, we're trying to do both, trying to shed light on issues that are of critical interest to people who live and work and govern in Illinois and in the United States and globally, and trying to understand trends, what to make of them, but ultimately we're also trying to think about how do we make things better, and making things better. Again, sometimes that means spending less, but sometimes it means spending more in the right places. And so we think very carefully about the effects of policies. Uh, you know, there are many proposals about how we can solve the challenges that we face, and sometimes those proposals they might work, but sometimes they have unintended consequences, or they might not work for everyone. And we want to know, who are they working for? How well do they work? Where can we improve them further? And one of the things that I emphasize is that many of the challenges we face in healthcare are big and difficult challenges. I mean, you see this even in like medicine itself, right? How do we cure cancer? Okay, super important question. We spend lots of money on it. Many of the things that people try to cure cancer have failed, or haven't worked very well, or not as well as people expected. And the response to that, failure is not to say, well, let's stop trying to cure cancer. No, curing cancer is very important. And the failures actually guide us in what doesn't work toward trying new things that do work. And so I follow a similar approach in how I think about solving health care policy challenges. How do we improve healthcare delivery as a system, as a business, as a public policy challenge, which is that there are many proposals about what to do, and many of those don't work. And we should not be surprised that things that sound good on paper often don't work in practice, because this is another very hard challenge. If it were easy, we would have solved it already. And so many of the things won't work. And that should not discourage us from applying, using rigorous research and evaluation techniques to identify the things that do work and the things that don't. One of the things that's important to recognize is that things that don't work are themselves costly, because we're spending time and money and resources on the things that don't work. And so finding out that something didn't work is actually a really big benefit, because it allows us to redirect the resources that we're spending on that effort toward things that might work better.
What is something you have found in your research and analysis of this gigantic issue, problem, however you want to describe it, that either surprised you and or you wish everybody knew? Like, if you could just get everybody to read this paper that you wrote about such and such a thing so we could all understand, uh, does something jump to mind?
Let me talk about a study that was run here at the University of Illinois. As we've been talking about, there's a lot of firms and organizations that are trying to find ways to reduce healthcare costs at work, improve their employees' health, improve well-being. The end result might be spending less on healthcare and having more productive employees. I mean, nobody wants to be sick. Nobody wants to be out of work sick, right? That's not good for anybody. So how do we do that? And there has been a kind of a focus on saying, well, people spend, a third of their time in a day sleeping, a third of their time at work, and the rest of the third is just running around trying to get everything else done. And if you're going to try to help people improve their health, one way is to think about things you can do at the work site. So workplace wellness programs have become really popular in the United States, adopted by most large employers. And oftentimes what these programs do is they offer incentives, sometimes financial incentives, like discounts on your health insurance premiums or financial rewards for taking steps to improve your health. And these steps are things like getting a healthcare screening. So you could think of this as biometric screenings, where a nurse or a clinician would take a small finger prick and measure your cholesterol and your blood sugar, and you get your weight measured. And then this could be followed up by a survey that asks you questions about your lifestyle. How much water do you drink in a day? You're eating enough fruits and vegetables and getting enough sleep. And then in combination between the biometric measures and the lifestyle survey questions, you can put together kind of a risk, identify health risks, things that you might be able to take steps to address now that will improve your health in the short run and in the long run. And so once you've identified those risks, then these wellness programs will sometimes also offer activities, steps people can take to mitigate the risks that they may face. So things like smoking cessation classes, or Weight Watchers for weight loss, or walking activities. And there have been hundreds of studies of employers that have rolled out these wellness programs to evaluate if they work. What these studies consistently found is that employees who chose to participate in the wellness program were healthier than the employees who were not participating. And when I was reading that literature, I was concerned that it could be that the employees that were already healthy were deciding to kind of might as well get paid for the things that I already do, the health that I already have, and get that incentive. It's something that in economics we call that selection bias, that there are differences in the health between the participants and the non-participants. That difference might have existed even in the absence of that program.
It wasn't because of their participation, right?
Well, that's the question. I mean, but it's also possible that these programs work. So I wanted to know, and so in collaboration with Julian Reif, who's another faculty member here at Gies, we worked closely with the University of Illinois to design and implement a comprehensive workplace wellness program. And we rolled the program out as a randomized controlled trial, which means that there were some employees were randomly split into two groups, and one group was invited to participate in the program. The other group was not eligible to participate in the program. And because those groups of the eligibility was randomized, there were kind of on average, there's no differences between those groups. So this is not that you don't get to voluntarily choose if you're eligible or not. That's done by a flip of the coin. Now, among those who were eligible, it was up to them whether they wanted to participate. And in fact, they participated in very high rates. We had very high engagement. And then what we did is we looked at outcomes over time between the treatment and control group to see if any differences emerged. And the idea is that if the program is having an impact on health, then you're going to start to see the treatment group looking healthier than the control group over time. At the end of the day, this was a little disappointing. What we documented is that the program didn't move the needle. Despite very high levels of participation, the program did not move the needle on most of the main health outcomes that people thought workplace wellness programs would move the needle on. And while that's kind of disappointing, at the same time, we want to know that. Like, we want to know that program, at least the way it was designed, we were trying to develop a gold standard program, but the way it was designed, it was not moving the needle. It might actually suggest that other programs are not working either.
Is your takeaway that, hey, maybe we can find the right motivation to get those people to participate? Or is it just like if they're going to, they're going to, and if they're not, they're not? There's not a whole lot from the outside we can do to motivate them. And I'll use this example. I talked to a well-known author and speaker, this was a number of years ago, who was never into health, never into fitness. He said, there's nothing you could have done to get me to work out except for one thing, and that was the day he had a heart attack. That, for him, flipped that switch of, this is important, I do need to do something about it, and that was the only thing in his life that would have moved him. All of that said, is there a way externally to influence those who didn't participate to participate?
Yeah, that's a fantastic question. One that people who design and implement these programs are constantly thinking about: how do we get engagement up? Our program had very high engagement relative to what many other companies get. One of the things we did was we varied the size of the financial incentive offered to people. So when people were invited to participate in the program, they were told, hey, if you come in, you get a healthcare screening. First of all, that screening is free. But for some people, we said, if you complete it, you'll also get $100 or you'll also get $200. So we could see, can these financial incentives help people to start taking those first steps? And in fact, those incentives did matter. They weren't enormous, though. I think a lot of what was driving the participation was that we had a program that was well designed. It was easy to participate. So when you showed up at work, there would be clinicians right there in your building or in a nearby building. So you didn't have to take much time out of work to have to do your healthcare screening. You didn't have to make a doctor's appointment and wait 2 weeks and worry that you're going to wait in the doctor's office for 30 or 60 minutes before the doctor will see you, right? Very convenient. And these are things that in fact we studied in this particular study: is how much does the money matter? If we boost the incentive, of course that increases the cost to the employer. If an employer is thinking about offering incentives, well, that's going to cost them more to run the program. They want to know, how much will that boost the participation? Is it worth it, or should they be allocating those resources to another area?
And then if and when the incentive ends, does that also end the participants' participation? They're like, well, I was only doing it for the money. I'm not doing it for my health. I'm out. So those are fascinating questions. And
I'm glad you asked that one, because in fact, we just released a new working paper that looked exactly at that in this study, where we looked at the people who were given an incentive. Because this program ran many years, we looked at what happened when that incentive was taken away. And in fact, a large fraction of the initial boost persists. Not all of it. So in the year that you're getting paid, that payment has the biggest effect. But the payment continues to have an effect in future years, even when you're not being offered it. It's about like 30% of that behavior persists. So there's definitely stickiness. There's definitely habit formation. And I think these bring up just great questions about how do we How do we get people to take care of their health? How do we design environments in which people are living and working that makes it easy for them to develop and maintain good, healthy habits?
I want to know kind of what has led to your passion for the issue. Obviously, as an economist by training, you could have gone a whole bunch of different directions with what you studied and where you worked. Why Gies? Why the business school? Why health? What sort of led you along this path to get where you are today?
I grew up in Minnesota. I went to the University of Minnesota for undergrad. Uh, for graduate school in economics, I went to MIT. And I also have, even though I was raised in Minnesota, I have family history from Champaign and UIUC. My grandfather graduated with a BS in architecture in 1941. So he went off and he served in World War II. And after the war, he settled in Minnesota. So it's kind of special to be working in a building where across the street is, where my grandfather attended school. So Illinois is just an outstanding institution. They understand and aim for excellence in everything we do. They support that. If you have a big idea, risky but big, impactful, this is a place where people are willing to think about big questions and how to tackle them. And that fits very well with the types of research that interest me. So how did I get interested in health? Well, I was sitting in a class in grad school covering health economics. Somebody put up a map showing the United States and showing how in different parts of the country, how much Medicare, so Medicare, again, that's the program for older individuals, how much the government spends on healthcare per capita in different parts of the country. And what was striking is that there were enormous differences across the country. Now, you might think, well, maybe that's because health, maybe the places that spend a lot of money are having better health outcomes. Actually, that's not true. In many cases, there's very little relationship between the total amount of spending in a region and the health outcomes in that area. In fact, you can take somebody who's age 65 in parts of Florida. Florida tends to has some areas that are higher spending. And you can take that individual and just imagine if you moved them to Minnesota and they spend their next 20 years in Minnesota instead of Florida, the government could also give them a Ferrari and they'd still save money. So there's just huge differences in healthcare spending that don't always align with health outcomes. And that got me hooked. I wanted to know why. If you look at life expectancy across different counties of the US, it varies dramatically. So for example, there's the county with the lowest life expectancy is East Carroll Parish in Louisiana. Life expectancy there is 69 years. In Cheyenne, Colorado, it's 89 years. So 20 years difference of life expectancy between these two places. Just enormous differences in health. People have said that your zip code is a better predictor of health than your genetic code, right? But I wanted to understand, like, is that because the place is shaping people's health outcomes, or is it that there are some places in the country where people move there, they're healthy, they want to live, they want to be in the outdoors to enjoy their health, hike, ski, swim, and so it's not that the place is making them healthier; it's just drawing in healthier people. And so that was an area that I've spent a lot of time studying, and of course this is tricky because people, when they live in a place, trying to disentangle, is it the place that's shaping them, or is it something about just that's different about the people who live there? It's hard to disentangle that. And so a lot of my work in this area, as well as in other areas, is using a combination approach, combining big data, so having a lot of data to observe outcomes for people, and then combining that with research design. So I want to make, I think, a distinction here because, sometimes people think, oh, if only I had enough data, I could answer all the questions. But you can collect all the data in the world, and there's something important that's missing from that data, which is that data only tells you the outcomes for the choices that people actually made. It does not tell them, it does not tell you what the outcomes would have been if they had made a different choice. So this is where research design matters, that you have to fill in that blank. You have to take a stance on what their outcomes would have been if they had made another choice. And so I have a study with Tatiana Derugina, who's another faculty member here at Gies, where we looked at what happened after Hurricane Katrina. So we looked at people who were living in New Orleans before the hurricane, and it turned out actually that the health, we were looking at people age 65 and older, and the health of that population was not great relative to similar cohorts in other parts of the country. So they just had poor health on average. When the hurricane hit, there was an immediate impact on mortality. Mortality went up. But what was really shocking to us is that in the years after the hurricane, the mortality of that group was much lower than its prior trend, almost suggesting that there was an improvement in their health, which, then you're like, wait, how does a major shock, maybe the most devastating natural disaster in US history, how does that improve people's health? And then we looked at the movers. So people were scattered from the shock. They moved to many different places. And some of them moved to places that were relatively healthy places, and some of them moved to regions that were relatively less healthy. And what we saw is that among the movers, their actual mortality outcomes correlated nearly 1-to-1 with differences in the health of the residents of the places they moved to, suggesting that place had a very big impact. Like where you moved shaped their health outcomes. And through my research, what I've come to be quite convinced of is that place has a large causal role in shaping people's health outcomes, their healthcare use. And that, I think, in turn can offer some insights in trying to understand why are some places better than others? What are they doing that's working?
Well, I, for one, am glad that Gies and you and your team are at the forefront of this research. I feel like we could go for another hour and I still wouldn't have all my questions and curiosities answered. I will say that as far as incentives go, when I'm 65, if someone wants to give me a Ferrari to move from Florida to Minnesota, I am in. So
yeah, you got to ask yourself, you have to have a garage most of the year.
I'm okay with that. That is just fine with me. Be sure to join us for the next Gies Download. In the meantime, you can learn more about the Gies College of Business at giesbusiness.illinois.edu.